Prathap, I'm Dr. Srinivas Kumar here.
Yeah, good morning, Srinivas. Good evening, Srinivas.
Yeah, good evening. I have Dr.
Yeah,
Sushil.
Srinivas.
I have Dr. Sushil Kodali, Liuka Testa, Eshpal, Mukesh with me. Ajay couldn't join, but Dr. Sushil is there in his place. Yeah. And please go ahead and introduce your case, and we are eager to see you what sort of CTO you're doing.
Sushil, Srinivas, we are actually, we'll start with our case. My colleague, Dr. Manu, will present the case.
Okay, good evening all. Our case is a 60-year-old female, diabetic hypertensive with history of class 2 effort angina for last 1 year, evaluated with the TMT, which was strongly positive for inducible ischemia. Angiogram done elsewhere showed single vessel disease, osteoproximal long segment CT of the LAD, and no flow limiting lesions in RC and circumflex. And they have attempted PC to proximal LAD CTO through antegrade approach to nearly 2 months back, but they couldn't succeed and so abandoned the procedure. Now patient came here for PCI.
We'll show the first angiogram. Today's angiogram we will show you. This is the first angiogram. It's a long CTO from the osteal LAD. Since it is an attempted one, we tried with the retrograde. So there are multiple collaterals here. We can see a septal collateral going up. Can you just freeze it out? There is a connection from the PDA. It's a small branch coming up and connecting. But there's a doubtful connection in between. Then go next. We have some epicardial collateral connected from the acute marginal going up to the mean middle AD. Then there is a cornus branch coming up and connecting with the LAD in the proximal part. So there are three connections, 2 epicardial, 1 septal collateral. We tried. Next. We have kept a wire that is called turn track wire in the LAD just for a RCA just for the support. Then we took a caravel with a cyan black wire.
Before we go forward at this point, can you give a little bit of your
just stop.
Thought process and to how you approached it? You mentioned earlier that that you or others had tried antegrade. So in terms of the technique, how you're going to approach it, what is your strategy up front? Just for the audience in terms of guide choice. And I think one important point is I don't do CTOs, but the key part of a CTO is the planning, but also your angios up front. You did a large field of view, you did in pan. And I think that's a key aspect that experienced operators do. You go back to that first angio, you could see everything and you can study it. When you start panning and doing multiple things in a small view, those would make it difficult. So if you could just go to this view here that you have and let us know what your thought process is when you see this and how you're going to approach it. Antegrade, retrograde, wire choice, escalation, what is your thought process?
If I can add on top of this question, which I
actually,
totally
Sushil,
agree. I would like to know, first of all, and this is for the sake of clarity, what is the main reason not to even try antegradally? Because I see that in this, particularly in this view, the CTO, particularly for an antegrade approach, is pretty short. So actually doing CTOs since more than 5 years, I will actually know why you are not even trying to do antegradally but just going retrogradally, because there is a lot of debate about hybrid approach, retrograde first, antegrade first. I mean, there are schools like in the US, like in Japan, like in Europe. So what is your process of understanding what to tackle first?
Prathap, when do you prefer
Usually
retrograde?
my approach is actually when somebody that is what actually when you try somebody already attempted antegrade, first attempt will be a retrograde for me. And number 1. Number 2, if a calcified CTO, long CTO, then also again I will try a retrograde. So these are the 2 situations I prefer: a tortuous anatomy where the ambiguous anatomy antegrade. That means osteoproximal LAD, osteoproximal circumflex CTO, osteoproximal RCA CTO, I prefer retrograde. So retrograde is preferred if a failed antegrade, a long calcified tortuous CTO, or a osteoproximal CTOs either in circumflex LAD or RCA.
In the initial antegrade attempt, were they getting to a dissection plane, or were they not able to enter the proximal cap? What was the mechanism of failure in the first attempt?
Sushil, actually we don't have a CD of that. So I thought maybe a dissection plane is created there.
see.
I will try retrograde. If I fail, then I'll go antegrade and try with multiple wire escalation.
Got it. Wonderful.
I
Thank you.
think you can go further. Proceed.
So next. See, we tried retrograde next with the, it's a caravel with, the first wire is a 10 track wire just kept for the support. Then this is actually a wire with a cyan black. There is a connection I created. There is a long, actually a acute angle there, so difficulty in taking the branch down. I took the wire down. And push the caravel down along with that. Taken the caravel out and we took a SO3 wire.
I actually have another question, if I can. Do you routinely use the Judkins right for retrograde approach, considering that, you know, probably the majority of the operators would have taken an AL1 for this kind of indication, considering the need for support? What is your approach in terms of catheter and support determination before
Usually,
planning?
no. Actually, Luca, basically, if there is a real good support with an JR, I take a JR. Otherwise, if there is no osteal disease, I may take, because I was planning to take this corners branch. Since I wanted to take a corners branch, I was actually thinking corners as a second choice. So since I wanted to take a corners, I did not take an amplats, because amplats may go deep inside. I may not be
That's
able
right.
to take the corners.
I see.
Always, if possible, we try to avoid.
Otherwise, I will
implants
be
because of-
preferring to,
Okay.
damage to the vessel. So this
Yes.
I tried with acute marginal. Again, I failed there. Next, this is actually a corners artery I took. Actually, because of the severe tortuosity, even a SO3 wire, multiple wires I tried, but it's not entering inside. So I don't want to damage the corners artery. So I
I
tried
think
again.
it's important to sort of point out, though, when you go through those type of collaterals, epicardial or conus, they're much more fragile than the septals, and the potential risks are probably a little bit more as well. So, you know, in experienced operator like yourself, Hans, I think it's reasonable to try, but I think for people that don't do a lot of CTOs, these are things that I would be very careful with.
Generally, septal collaterals are to preferred over
Yes.
epicardial.
Sushil actually, it's actually perfect, because since the septal collateral I did not get, I took with epicardial. But whenever I take an epicardial, I'll be very careful. I don't want to damage the epicardial and not to create a perforation. Once you create a perforation, it will be end of the procedure. So
Yes.
I was trying my level best to take into the vessel, but that because of the tortuosity, it is easy to take a caravel up, but the tortuosity will not allow the SO3 to go up. Next.
But some
I
of our
tried a
friends who
different
couldn't
angle
join
here.
here, you
Actually,
can
we are
inform
here
our entire proceedings are being relayed live in our website as well as on YouTube. If somebody cannot join here, they can watch if some of friends are interested. Anyway, go ahead, Prathap.
So this is the situation now. I shifted the wire, but that is also not going. Probably I will try an antegrade now. This actually, you see the tortuosity there, very difficult.
Which wire is that?
See, the wire is actually taking, this is actually, I tried with the SO3 failed, then I took a XTR.
Normally, many of us who not that comfortable with retrograde would try antegrade and then go retrograde if one fail. You are doing the reverse. CTO specialist.
No, I'll try antegrade. Can you just give me a wire? Now I'll go to the antegrade.
If you see a small track positively, I think that helps us to edge. more
Basically,
towards,
you see, this is a ostial. You see,
small
you can't
stump.
see that very well.
You can see an entry point there potentially,
small
right?
tab,
Yeah,
entry point.
there's a peak there.
after
Can
the
you
first
just give
attempt
me a
failed
XTR?
anti-gradely,
I'll
you
try
may
with an
actually end up
XTR.
in the same situation
Yes.
in the section.
Yes.
And but of course, there's a problem. But I have to say that at least the first half centimeter is into the true lumen. So at least you got an indication where you have to push, because it seems like it's relatively straight, although it's calcified, maybe dissected and whatever. But looking at the retrograde possibilities, I have to say that all these tortuosities are just a nightmare. So, I will try anyway.
What is the wire you are taking for antigrade?
Now basically this is an osteal. Now antigrade I'm taking a XTR with a fine cross. XTR with a fine cross. The problem is actually this osteal CTO. You may lose it by just one pushing of the wire.
Okay.
So that is why I was thinking that it may be a real tough type, because you can see a small track there, but I don't know whether it will be easily going inside.
For the sake of delegate audience sitting here, whenever you feel there is a small antigrade track, nowadays we have this fielder XTR wire which generally tracks well through it. And if you are absolutely sure that there is no track, then you can take directly stiffer wires. Most of the times, whenever you feel the faint track is there, you could get away by doing a fielder XTR which has a 0.09 thickness and is more slippery and could go easily whenever you have any faint channels. So whenever you suspect a faint antigrade channel, use that. And when you're absolutely definite that there is no channel, then you can use more stiffer wires. I think there's a possibility of faint track. Only problem here is when people who it's tried elsewhere, the track could be going into dissected path. If it is of some time, it is okay. That's the only thing which you need to worry.
Yeah.
And these wires also tend to slip into wrong tracks too.
The guide here seems a little bit big, making it a little more challenging, sort of pushing you, angling you towards the.
LCX.
Yeah. This is an EBU 3.5 or?
Guide is
EBU 3.5.
3.
Guide is sitting towards the circumflex.
Circumflex.
That's the challenge here.
Generally,
Guide is sitting towards the circumflex.
generally
Otherwise,
LCX we plan 3.5 and LED you tend to take 3. Maybe because of bigger size you must have planned for 3.5.
But you can see 3.5 actually. We take always a 3.5 or 4 in CTO because you will get more support.
More support, right.
More support with a larger curve.
Yes.
3.5 or 4 you get a more large support. So
Okay.
otherwise you have to take an amplats, because I was thinking that it is not required amplats here. So that's the second choice of, if retrograde I fail only, I was trying for an antigrade here.
You always take the help of a microcatheter like Tornus or any other microcatheter with this wire, or you do try before without that for free movement?
Tornus I don't, Tornus, no, I will.
Yeah, some sort of support.
No, I will always take a microcatheter for CTUs.
You try sometimes even without the
Some
taking?
microcatheter I always take.
Always take, okay.
Yeah. No, always name. Actually, some of the situations I try with a microcatheter, without microcatheter also sometimes I try. If there is a real, if you feel that if it is successfully, and it is high possibility that you can be successful, then I try with that other also.
Okay.
See, the wire is not sitting there. I'm actually pushing my microcatheter so that even if I wanted to take a tougher wire, I can take with that wire. If I am sitting
This is
towards
actually one of the limitations of the fielder wires, because they are very slippery,
Very slippery,
lubricious,
and also-
but the torque ability is not. They have been created actually to navigate into microchannels.
Yes.
So when you have bends, they are actually in trouble. So, unless you can achieve a better position with the tip of the catheter, it's going to be a problem, because of course, although you may customize the tip, still the torque ability will be poor. These wires have been created to navigate into microchannels. That's what they do.
Yes.
So sometimes can be a problem if the position of the tip is actually going towards the LCX when you have to tackle the LED. But I think that some kind of manipulation may help.
So if this doesn't go, options are change the guide to EBU 3.0 or use another wire to help engage the lesion, get the microcatheter in, and then switch to the XTR.
That's right. One option would be exactly to put a wire into the LCX, actually to adjust the position and the angle of the tip of the catheter, but still there are some possibilities. It depends on your practice, actually.
And one thing you have to be cautious about when you're doing this is you get so focused on the LAD CTO, you forget you're working left main circ, and you get into a dissection that's just proximal, and then you end up dissecting down the circ, and that's what you have to be very cautious against.
Yeah.
Ideally, Sushil, you have to put a wire into the circumflex and keep the LMCA to be preserved, you know.
Yes.
That's actually the ideal situation. Here I am thinking that there is a possibility that I can put the wire at any point of time.
Another option could be to
It
use
is
a very
not sitting
torqueable
there.
wire like
Here.
cyan blue or something, just to get into the stamp and,
Yeah,
to
but
navigate
the
with
next
the
plan is to take
microcatheter
a cyan
and
black.
then
Can it be
exchange.
cyan black?
Because, you know,
Yeah,
I don't see any potential for the field to get there.
cyan black.
I agree.
We will be going to take a cyan black now.
What is your most preferred wire nowadays for CTO?
I actually take a cyan black or a cyan wire as the first wire. Then I will switch over to XTR if there is a micro channel. Then I go to Gaia second, then Gaia third. If there is no possibility of opening up, go to Miracle 6, Miracle 12 and Congress Pro 12. If this graded escalation is not possible, then we will go directly to the retrograde. And if fails, reattempt. That's the point.
Apart from the CTO scores, calcification, long track, which are all worrisome, what I am always worried is it's attempted elsewhere, it's failed. I think we need to be more careful and plan our procedure well, because there could be some trouble created with the previous procedure. And if it's sometime lost, it is fine. But if patients come very early, I think you need to be more careful.
We make a double curve in this case because the vessel catheter is actually facing towards the circumflex. That is the major issue here.
Yeah. Pratap, as you are
Because
trying
it
with
was
another
facing
wire,
towards
can
the
we,
lady, it was easy.
Pratap, as you are trying with another wire, can you go for 10 minutes to
You just-
other center and come back? Is it okay with
Ah,
you?
yeah, please.
Okay,
Please,
we'll
please,
come back.
please,
We'll come
please.
back for
Yeah,
last
yeah, please.
last 10 minutes to see result. Pratap,
go,
we are
go,
with you
go.
now. Last few minutes. You want to say?
Yeah.
Yeah.
Yeah. Actually, what I tried, what I tried is actually I'm not able to pass the wire down. What I did is actually I switch over to the catheter. Back. See, this catheter was not able to go. Then I switched over to 3. EBU 3.
Okay.
Next. I switch over to EBU 3, which was looking exactly into the
Into
LED.
the LED. That's what Sushil
So
was
I took
mentioning.
a wire again, a cyan black. Yeah. That into the LED now with the microcatheter. Then what I did is actually I pushed the wire. This actually it switched over the wire into Gaia second. Gaia second crossed the lesion. Once the Gaia second crossed the lesion, it went into the diagonal. Then I kept the microcatheter in the proximal part. Pushed next.
That's why it's very important. Many
What-
people
what
think
wire?
guide
Then
support.
I
The guide
switched over
support
to
is
the-
not important. The positive angle and coordination and
No,
direction
the-
of guide becomes very important, especially.
Sushil,
it is.
Sushil was asking which wire. The first wire actually, the cyan black actually, with the help of cyan black, I went into the proximal cap. Then lesion was crossed with the help of the Gaia second with the microcatheter.
Okay.
Now I removed the microcatheter. Now I am actually taking the balloon inside. Now wire is in the distal part. Now I cross the lesion. Deflate.
I have to say that this kind of situation are really hard to anticipate, but it can happen that after the first attempt of antegrade approach, after this dissection, you can have a process of positive remodeling. So in that case, the artery gets bigger, so the second attempt of rewiring antegradely can actually be more facilitated, I would say. I will not say easier, of course, but definitely you have higher chance. This is why actually the second attempt is always better than the first, because you know what you have to do, and the job done before can be helpful, despite it wasn't actually a failure. Indeed, you see that that's,
now
yeah,
the
that's
vessel is
pretty
opened
normal.
up.
This is
Now
pretty
it is
normal.
actually just
Now this dissection is visible because the antegrade injection fills it with contrast. So that's why you see this dissection. And basically, when you are crossing a CTO, you are always creating dissection. There's no matter what, you are doing that. Now is.
no, I think it can be even created by the balloon also. I would have dilated with the balloon with the 2.5 high pressure. So that also would have created dissection.
Good dissection, good preparation.
So the
Now we have
CTO
put a
ended at the bifurcation of a diag. Would you put another wire in the diag now, or would you?
I think so. I think so. I mean, the
it
diagonal
appears
look
that you
reasonably
can
good.
You can end at the junction.
That's the question. Do you have to put another wire and try, or would you image at this point to see if your true lumen
No,
at the
we have to
level of
put a
the
wire.
circulatory?
No, we have to put a ideally, Sushil, before putting the stent down to the ostial LAD, we have to put a wire into the circumflex before doing that, because LCX.
Yes.
Yeah, that's always very important because of the, see, we have ostium is very well seen, and you have like a T shape. So even if there is a problem, we have a chance. It is almost like a T. We can exactly put the stent at the ostium of the LAD.
Now you
By
can
definition,
the
we really don't know. The ostium is really tight.
The right guide and wire, can you remove now?
Right, remove. I am going to remove. Yeah. Everything I am going to remove it. I just put a wire into the circumflex and then we can do an IVUS and see what is the size of the LAD. Probably it look like circ is looking like 3.5. LAD looks like 2.5 by angiographically. I think it will be 2.753 minimum. What do you think?
Yeah. No, I think it's got to be at least 3, and this is where, especially in a CTO, there's negative remodeling, there's plaque, things look smaller. Where imaging may play an important role. I would put a minimum of 3, but it may be bigger if you on imaging sometimes.
What is the size of the last
I
balloon you
I
used?
actually even. No, Sushil, actually the left main looks like 4.5 to 5 with a 3.5 circumflex. Minimum 3 millimeters should be the LAD.
Yes, that's what.
Luca was asking what size balloon
Actually,
did you use?
2.5. Said 2.25.
2.5. No, I used a 2.5 balloon.
It's always safer to wire LCX before do anything, because as we said, discussed before.
Yeah, I already put a wire. Now, whether I have to do an IVUS and to show, or I can put a direct stenting.
We are left with you for 5 minutes, for 4 minutes in fact, Prathap. I think
4 minutes is sufficient for me to show the IVUS.
stenting or IVUS? Okay. You can go ahead and show the
IVUS, anything, whatever you want.
Yeah, ideally what is
IVUS,
correct
what
we should
I
show.
want.
You do IVUS and assess the vessel size, and probably you can take the stent.
Yeah.
I mean, the rest of this is sort of cleanup and routine strategy at this point. So the IVUS and see the stent size and strategy is the more important question.
Mukesh, anything you want to say?
Fix the wire.
Whatever you're comfortable with, first that should be done. Then I think, then when you fail in that, then doing all other things come.
Okay, IVUS.
Can
You
we
can
see
see
the
the
IVUS?
IVUS now?
No.
Can you show the IVUS image?
We can't see it yet. There we go. Now we see it.
Can you? Okay. Severe plaque, actually, large plaque. You can see the plaque. It is in
One,
the
two,
totally
three.
in the lumen.
Minimum 3.
Will look like a 2.75, yeah, maximum 2.753. That's
Yeah,
all.
3, yeah.
3 millimeter is the stent. Now it is you can see the severe disease in the
Yeah.
osteoproximal part. I think you have to do some more dilatation in the proximal part before putting the stent.
See the nice dissection there.
Yeah, dissection is
A dissection also you can see, but there is a severe, plaque is severe.
yes.
Now comes to circumflex. Circumflex osteum will look no disease, and LMCA is look like 3, 4, 4.5. 4.5. So 4.5 circumflex, I will put a stent exactly from the osteum. I'll try.
Yeah, I agree.
So
I mean,
we will put a
even
3
if
millimeter
one
post
strut
again
will be
dilatation.
hanging in the left main, nothing's going to happen. It's so big that you can afford to do that. But also, I would like to draw the attention to the fact that the eyeballs nicely showed that the wire is exactly into the true lumen. So we didn't see any effect of in and out. So the dissection is a consequence of ballooning and maybe of the previous procedure. But definitely this wire is in the true lumen. So you can actually transform this in a conventional PCI from now on.
Yes. I think what is you
There is actually
planning to take which stent? 3 into?
I'll be 3 into, no, we will be putting a 3 millimeter stent, 3 into 18 or 24.
I think the proximal
It's actually a
portion can be
3.25
optimized.
size
Yeah.
by the IVUS.
Okay.
Yeah. We have to take a 3.5 millimeter post dilatation by 8 millimeter, 3.5 into 8.
When you have to
a
exactly
3
position the
millimeter
stent at the osteum, probably stent like Zines, which has a marker, exactly starts where the stents could have some advantage in this osteal placement.
Yeah, exactly.
Other things. I think, Prathap, you are worried that Bhatia says we might lose you at any time, but we'll be with you till then. And thanks for excellent demonstration. And then again, antigrade technique could solve the purpose in this, and then retrograde was challenging. Sometimes life is funny; it shows different ways. And you have shown, we have seen Goel showing one left main crossover, and we now saw the osteal LED opening. We'll probably finish it with positioning it right from the osteum to the LED, and without coming anything to LCX. Any final comments,
Sure.
Prathap, before we close?
No, thank you very much again giving me a chance along with Srinivas, always give me a chance to do some demonstrations. And this time it is a third live show I am showing in this year with IGCTO 1 and 2 with Srinivas. Thank you, Srinivas,
Thank you,
so much.
for
Prathap.
giving us a chance to show all these things.
And Sushil wants to welcome you to
Thank you.
TCT USA in San Francisco.
Yes. Look forward to it.
Sure,
All right.
sure.
Thank
I'll
you
be
again.
there, Sushil. I'll be there, Sushil. I'll be
Yes.
there, Sushil, on day after tomorrow.
Actually,
Tomorrow
I
evening
requested
I'll be
him to
there.
conduct our
Thank
CSA
you.
NIC session in there in TCT San Francisco. Thank you. Congratulations. Let's give a big round of
Very
applause
good, very good.
to
Thank you,
Prathap.
thank you.